Okay, good afternoon and welcome to today's webinar, Give Me Base, Setting Meaningful Baselines, presented by QRM. We're thrilled to have you here today, joining us from all over the country. I'm Amy Gerlach, VP of Marketing and Communications here at QRM. QRM is a leading provider of in-house rehab management, servicing skilled nursing facilities across the country. In addition, QRM also provides an extensive range of services encompassing MDS support, medical review, talent placement, marketing services, and much more. So before we get started, I'd like to go through a bit of housekeeping items so we can all have a seamless experience today. Firstly, the webinar will be recorded. So if you need to step away or if you'd like to revisit the presentation later, don't worry, the recording will be available on demand. So what we'll do is we'll send you an email after the event with a recording link, and that will be sent to you within 24 hours directly from Zoom. Second, we do have handouts available through the link that we will be placing into the chat area in your Zoom control panel. So go ahead and look there. You can follow along today if you'd like. Also, we definitely welcome questions. You can submit those throughout the presentation in the Q&A box that's also in your Zoom control panel, which is typically at the bottom of your screen, or it may be at the top depending on your settings. So again, we encourage you to ask questions, and at the end, we will try to address as many as possible. Any that we can't get to, we'll be sure to address and follow up in our post-event communications to you. So now, without further ado, let me introduce to you our dynamic duo who will be sharing their expertise with you today. We have Mark Heider, QRM Vice President of Reimbursement Strategy and Education. He has nearly 30 years of experience in the skilled nursing industry and is recognized for both his clinical and operational achievements. Also presenting, we have Megan Ussery, QRM Director of Clinical Reimbursement. Megan is RAC certified and has over 15 years of experience with a focus on reimbursement and quality care. Together, they will be guiding you through the need-to-know strategies to successfully navigate the impending CMS changes. So now I will hand it over to Mark, who will get us started today. Enjoy the webinar.
Thank you very much. We really want to welcome you. We're very happy to be spending time with you today, talking about some really important items. Y'all know that this is a time of change, but one of the things I want to really reinforce is this is a broad overview of the changes that are proposed. We'll obviously be seeing the final rule and the changes that actually will occur in October, but this is a great time to start looking at creating a framework for you and your team to implement those changes, to make sure that you have the resources available. And as leaders, that's really what we encourage you to do, is make sure you're looking at this as a time to set that strategy in place and make sure you have the time, resources, opportunities for your teams to learn and progress, so that October 1st is just another day. It's a change, but one that you're prepared for. One of the other things that I want to mention is we will be doing additional training, more of a deep dive in some of these topics that we're talking about today, and we'll be doing that broad overview of. And like Amy said, we do welcome your questions, so enter those. If we have time at the end of the hour, we'll probably answer a few of those. But we will be creating a document, a frequently asked question or question and answer document that we'll send out. And finally, I want to reiterate another thing Amy said. There will be links for the handout and the recording sent out. So we want to make sure you have the information that you need. So we're going to move right into our slides, and Megan's going to get us started off with what's been kind of breaking news. It was announced and rescinded and resent out in a different format. So I'm going to turn it over to Megan.
Thanks, Mark. So of course, with this breaking news, we can always count on CMS to keep us on our toes. releasing things and taking them back and then re-releasing. But to start off with this particular bit of news, so on May 4th of 2023, CMS alerted providers of a 5-claim PDPM probe review to be conducted by the MACs for really every SNF in their respective jurisdictions. And that will be effective essentially June 5th of this year. So the purpose behind this widespread review, of course, from on CMS's side, is to lower the SNF improper payment rate. And so we did discuss this on last week's webinar, but CMS has since, as you mentioned, made a clarification. The original transmittal was rescinded and replaced by transmittal 12037, dated May 15th. So this was just 2 days ago. And they did that to clarify that claims will be adjusted and or denied if an improper payment is identified. So they left that little tidbit of info out in the original transmittal re-released another transmittal saying that if any improper payments are identified, those claims can be adjusted and or denied. So let's go through a couple of takeaways on the next slide and what you guys can do to be proactive. So of course, proactive is the key when we're talking anything related to medical review. It's important to know that this will impact every single Medicare A SNF provider. So it now is a great time to do some internal auditing, develop a system for managing this process successfully. And so in order to do that, you'll need to take a couple of action steps. So notify your billers to ensure timely identification of these requests. Make sure that you validate your facility address on file to ensure that you actually get that correspondence from your MAC. It's hard to respond to those, these requests if the mail is going to the wrong place, right? Ensure that each of your claims are backed up by source documentation. So we need all of that documentation in the medical record to support what we're billing, to Medicare on the claim. And then, of course, establish an internal process for assembling these packets, submitting and tracking that documentation.
These are really good points, Megan. And one of the things historically we've seen is facilities get stumbled up for a couple of reasons. One is timeliness of their response. So letting people in the facility know that there is a review coming up and how critical it is because it is a prepayment review. The other thing is that the completeness of the packet that's being sent in. And your point about looking at your PDPM scoring and send the documentation that supports those PDPM levels is very critical for the teams to send in order to pass that first step. And unfortunately, this is a one-step review. It's that whole TPE process, except it's not a 3-step process. It's a one-step process. So great input there. So in our agenda today, we're going to present the proposed CMS changes for the SNF sector in a really, hopefully, a simple, clear, concise manner. We want you to be able to take something away from it and this be meaningful to what you're doing. And this is going to include some of the SNF QRP and value-based purchase changes. We're also going to provide the sources, resources, and a timeline for the upcoming changes, and then a breakdown of Section GG. And this should be in terms of the administrators, DONs, and other SNF leaders can understand and encourage that involvement in that process. And lastly, to build a simple framework for managing the CMS changes.
All right, let's do a quick poll question. We'll go ahead and get that pulled up here. Get some interaction from the audience. All right, so the proposed CMS changes for fiscal year 2024 are scheduled to take effect when? January 1 of next year, October 1 of this year, November 1 of this year, or July 1 of 2024 to coincide with most state fiscal year changes. Give it about 5 or 6 seconds. All righty. Yeah, so fiscal year 2024 is October 1 of this year. All the changes are knocking on our doorstep.
Okay. See if we can keep this moving. There we go. Glad that everybody seems to know when the changes are occurring. Last week when we spoke to the last group, we had the end of the public health emergency coinciding with the day that we were presenting. And, where we like to think that, man, where we made it through, smooth sailing now, we're just going to continue to move forward in a really an easier environment to work in. The problem is every year we have all these changes, and it really causes an upheaval, really causes a little bit of chaos because we get the proposed rule, then we get a final rule, and then we have to implement those in a pretty short framework. And usually there is a lot of administrative type duties that have to be performed. There are changes, there really is additional work that we have to plan for. So when I was looking at some of the quotes on chaos and storms, I found this one. Sometimes there is no time to wait for the sea to calm down. If you have to reach your target, let your voyage start and let the storm be your path. Hopefully, it's not too stormy, but as you'll see, the changes that were proposed are pretty significant. They're not just significant to the processes in your facility, but they're significant to your reimbursement. And they're significant to the perception of the community of your services, because some of these will be shared on Care Compare, which is a public-facing webpage the government uses to report the care that you're providing. So super important, because fiscally, as well as perception of the community, there are a lot of changes that will impact you coming up. Now, one of my pet peeves is chaos and what I used to call, and still do, rules of thumb. People come up and when questions are posed, and when I was a young therapist just starting off in the skilled nursing facility setting, I would ask people about rules. And everybody would say, oh, do it this way, it's a Medicare rule. And then somebody else would contradict, no, do it this way, it's a Medicare rule. But nobody seemed to go to the source document. It was always learning as you go. It was learning on the floor. It was just learning from the person that you were working from. And of course, the manuals weren't on the internet yet, but now they are. So one of the things that we decided to do as a team is say, you know what? The first thing we're going to do is share the sources. While they're in the back of or the end of the webinar, and they're great as a reference, the one thing you should do is read enough of the source to understand the material yourself. One of the weaknesses we have as an industry are leaders who don't understand the business side. And that means not just the financial, but it's the rules and the regulations. What are those source documents that guide our industry? So one is the Federal Register. It will be updated again. It's been updated. One of the other good things is there are a lot of professional organizations that support our industry that have written white papers or summaries of the proposed changes. Read those and then click on the link to the source document and read those sections that are relevant to those changes that we need to be accommodating and planning for. The other sources that we put in here were related to our quality measures, our value-based purchasing, and the SNF QRP, because there are specific documents, there are guides out there that help you to manage these processes. So let's be ready for those. Let's use the source documents. Don't use rules of thumb. So-and-so said, so-and-so always does. That doesn't work. And one of the other things is with your MDS nurses and your other nurses, your medical records people who keep their cheat sheets with ICD-10 codes, those change every year as well. So need to make sure that we're using up-to-date information. And again, they're source documents for that information.
You are so right about the changes. I feel like if we were able to make a cheat sheet, CMS is changing things so often that it's going to be obsolete very quickly. So let's go over these proposed changes. So the good news, some good news here handed down with the 2024 proposed rule is that 3.7% aggregate increase in fee-for-service Med-A payments. So this does include the second half of that PDPM parity adjustment recalibration. This was, big news not too long ago. When PDPM was implemented, of course, CMS thought that would be budget neutral. It turned out that was not really the case. And they had some, accounting issues on their side. So they implemented that parity adjustment. So that 3.7% aggregate increase does include that parity adjustment recalibration. Do keep in mind that this increase is not going to be, distributed equally to all facilities. It's not like we're just splitting up the money and sending out checks. There are some stipulations that we'll get to here in just a little bit. And then some other good news is that for these proposed changes, CMS is giving us some, providing us notice and giving us some time to adjust for the future changes. Things coming further down the line, like the vaccination reporting, adjustments to the MDS submission thresholds, and a couple of other things. All right, so now maybe for some not so great news, the minimum staffing requirement. So the current administration has voiced its intentions to implement more rigorous staffing requirements. I think everybody kind of finds this as a kick in the gut, especially during a time when staff are hard to find. And I feel like everybody is in some sort of a staffing crisis. So this could rub some salt in those wounds for sure. CMS has solicited and has accepted provider feedback through implementation of a mixed method study that began in August 2022. And they're going to announce sometime, quote unquote, this spring, what those proposed staffing requirements would be. So we're really just kind of sitting and waiting and expecting that announcement anytime.
Now, obviously, spring ends in about a month. So we got to keep our ears open and really watch for this change, because it could be one of the biggest changes or biggest mandates the government's put on us for quite a while. So big change, but we don't have the details yet.
All right, so just to hit an overall, kind of in a nutshell, what we're going to look at throughout the rest of the webinar, there are a lot of changes coming to multiple areas that impact reimbursement and quality. So we'll dive deeper into each of these. But just as an overview, we're looking at new MDS item sets, new and updated ICD-10 mapping changes, looking at changes to quality measures, and then multiple additions and revisions to the SNF QRP and VBP programs. So to kick it off with the new MDS, so the highly anticipated draft MDS item set was released in September of 2022. The draft RAI manual to accompany that and the final MDS item set were both released on April 4th of this year. So these changes will go into effect October 1, 2023, so this year, which is the start of fiscal year 2024. And we've included a link in the handouts, as you can see right there, to the CMS webpage. You will always find the most up-to-date information at that link. Okay, so talking MDS changes, most notably, Section G goes away, right? I think that's the section that's had the most chatter surrounding it, but there are several other sections of the MDS that have changes as well. So we'll have additional webinars, as Mark mentioned, to tackle each of those changes. But in a nutshell, there are, some pretty big changes to sections A, D, J, K, N, and O. So we'll have more information coming up about those. Now, when I said that Section G is going away, it is. However, states still have the option to request use of the OSA, so that optional state assessment, for Medicaid CMI purposes. The OSA does still have the traditional 4 late loss ADL questions in it that we're familiar with from Section G. And they utilize that same verbiage. So we can't fully send Section G out to pasture just yet if you're in a state that plans on using that OSA for Medicaid purposes until the end of 2025. And then, so in talking about that OSA, here is the link to the CMS webpage where the final OSA item set is housed, if you're interested in seeing what the contents of that are.
Great. We're going to kind of move forward into quality measures. And we know quality measures do a lot of things for us. One of the things that is discussed frequently, and I hear those conversations, is do quality measures accurately reflect the care that's being provided in the facilities? Well, here's the deal. The federal government, CMS, is saying that's what they're going to use to represent the quality of our care. So whether it accurately reflects or not, these are items that we have to continue to work on. And we know that several of the quality measures are going to be retired, amended, changed, replaced. It's just going to happen. And we also know that the retiring Section G from the MDS is going to impact our quality measures, because that is generally what guides those quality measures that have to do with mobility and function. So there are additional changes coming up. Now, we know because quality measures are affected, the SNF QRP and value-based purchase will be affected. But some of the other things you're going to watch for are the Medicaid pay-for-performance type programs and the CMS 5-star program, because those quality measures do impact that. And whenever we talk about CMS 5-star, one of the things I like to remind people, and I know that you know this, but I want to remind you, is that the 5-star is your publicly reported, public-facing information. And 15, 20 years ago, people didn't go to the internet to look at reviews like they do now. And just like you do a Google search or Yelp or anything like that, looking at businesses, this is where people are coming to see your information. So you want to make sure, quality measure-wise, you do as much as you can to keep those 5-star ratings up, because we know that staffing and survey that also affect the results in your 5-star aren't as controllable as your quality measures. So need to really pay attention to those.
All right, poll number 2. Let's get poll number 2 pulled up. So regarding SNF QRP, the data collection year for SNF QRP items is the year immediately prior to the payment year. True or false? Give it just a couple more seconds. Let folks get their answers in.
We're pretty neck and neck on this one.
Suspense is killing me. All righty. All right, we got 59% say true, 41% say false. Mark?
It is false. It's usually 2 years prior. So if we were tracking our performance in 2023, our payment year would usually be 2025 for most of those things. Okay, let's keep moving. Now, getting back to the quality measures, we're going to move into QRP. We have the adoption of 3 new measures, the removal of 3 measures, modification of 1 measure, and a proposed change to the reporting threshold. So all these things are proposed, but it's very likely that they're going to happen, so we need to be ready for them. A couple of the biggest. We have a new discharge function score, and our score is going to be compared to a CMS's expected discharge benchmark. Now, the interesting thing is they also have a formula. If your information is missing and you have blanks in your MDS, they're going to estimate and compare your results to their expected results. Let me warn you, almost every time we've seen something like this, it is advantageous for our facilities to track their own performance, their own metrics, not allow CMS or any other provider to use some type of matrix or their own calculation to figure it out. So super important that you're looking at function, and that's using that proper baseline or setting a proper baseline and then an outcome measure. They're going to use section GG information, and they expect residents to exceed or meet their discharge goal. Before, we were just really tracking if we were checking the right boxes. So it was just completing those sections and having a goal that they were looking at, not the level of performance. So we've gone from just reporting to actually measured outcomes here. Super important. It's also being proposed as a value-based purchase metric. So we're going to see this at least twice. And both QRP and value-based purchase are payment items. Those are pay for performance programs, which you already know. So a potential 2% impact eventually if you don't do well on these measures. COVID vaccine, the percent of patients, residents who are up to date measure. And it's a change because we're going to have to continue to, well, they're adding it to the QRP, but the change is going to be with our employees as well. So we'll see that in one of our other measures. And additionally, in the QRP, we've got the core Q. Now, we've been told for years that they're going to start measuring our resident satisfaction. It's a 5-point Likert scale. There's a progressive submission plan, so you're going to have to submit. Otherwise, you're not going to meet their metric. But here are the questions, and they're pretty simple, pretty straightforward. And these are things I would start working on today if I were you. First question, in recommending this facility to your friends and family, how would you rate it overall? Overall, how would you rate the staff? How would you rate the care that you receive? How would you rate how well your discharge needs were met? And then there are two, we'll call them gateway questions for a lack of a better term. Did someone help you complete the survey? And how did that person help you? So it's customer satisfaction. It's their perception of how well you did and your team did. So I mentioned a threshold. There are actually two thresholds. One is a 75% submission of the weekly resident info files to the CMS approved CoreQ vendor. So are you sending the files, at least 75% of them? And then there's a 90% completeness of the resident files. So CMS explained it this way. In other words, SNFs would need to submit resident information files on a weekly basis that include at least 90% of the required data fields to their CMS-approved CoreQ survey vendors for at least 75% of the weeks in a reporting year. So you've got to send those files in. When this kicks in and starts, you have to have a plan in place to complete them, 90% or more, and to submit them 75% or more. And if it's me, I never set the benchmark at 75% and 90% if those are the low water marks, and that's where there's a potential impact on my revenue. I'm going to set a higher benchmark, 80 or 85% submission and 95% completion, just to make sure you're not living dangerously. A couple of the proposed eliminated measures is the application of percent of long-term care hospital patients with admission and discharge function assessment, care plan that addresses functional measure. Second one is application of the IRF functional outcome measure, change in self-care score and change in mobility score. These are those measures I was telling you about that just are checking the boxes. Did you set a measurement? Did you set a goal? Are they on the care plan? So again, our discharge function is going to replace just these measures that ask us to complete the task, not measure the task. And then a modification. COVID-19 vaccination coverage among healthcare personnel. This is a big change because the prior version measured whether the healthcare personnel had received the primary vaccination series. So originally, did you receive the vaccination series? This new measure that's proposed will report whether they've received the COVID-19 vaccinations as per the CDC's most recent guidelines. So it's a small change, but a significant change. So that is something to start considering. How are you ensuring that the vaccinations are offered, tracked, and that you are protecting your residents by trying to get your staff vaccinated? But a small but significant change, like I said. Now, the other piece is the QRP reporting threshold. Currently, 100% of the qualifying MBS fields must be completed on at least 80% of the assessments submitted to CMS. So again, are you checking all the boxes, right? Are you sending 80% or more into CMS? Got it backwards, my apologies, but 80% of the assessments have to get to CMS, okay? And then they're proposing that 100% of the qualifying fields have to be completed on 90% of the assessments submitted to CMS. So it's the completion of the boxes. It's the sending them into CMS. It's making sure that you're looking at dashes. If your team are dashing a lot of the fields, the qualifying fields, you're going to be in trouble because the measure is going from 80% to 90% of those MBSs that are transmitted to CMS. So again, I'm going to correct myself. It's completion of the fields. So the potential penalty, 2 percentage points to the applicable fiscal year annual payment update. So you could lose up to 2% of your Medicare revenue, your Medicare Part A revenue, by not completing this. You have a little bit of time to work on it. The change timeline is fiscal year 2026. But here's where I want you to go back to that poll question. Usually CMS is measuring performance prior to announcing something. So we need to start working on it so we're not actually in a measurement year when they start applying a penalty or a reward. Two other issues that haven't been on their additions to the QRP. Transfer of health information. There's two different transfers they're talking about. One is to the provider. One is to the patient. And it's going to be similar to when you go to your doctor and you receive that printout that tells you what medications they've recommended or what their recommendations for your condition are. That's similar to what we're looking at. So this measure reports a percentage of patient stays with a discharge assessment that shows that a current medication list was provided to the patient family caregiver and the subsequent medical provider. And the timeline, CMS would like to start reporting this on Care Compare in October 2025 after their site refresh. So bit of a change, but it's something we've seen in the past. It's similar to what you receive from your physician, your provider. So I think it's a reasonable one. It's the tracking. It's the making sure there's documentation. It's making sure there's a process in place so this happens like it should every time we have the opportunity to provide this information.
All right, let's talk value-based purchasing program. So now we've hit on QRPs. Now we go to VBPs. You know, all the acronyms here. So within the SNF value-based purchasing program, we're looking at 4 new quality measures, replacement of 1 quality measure, and a couple of policy changes. So for the 4 proposed additions, we've got nursing staff turnover, the discharge function score measure, inclusion of the long stay hospitalization measure, as well as the long stay falls with major injury measure. And some of these are probably familiar to you. We're going to go into them in depth here in the next couple of slides, but let's start with the proposed addition of the nursing staff turnover measure. So this data is already collected via PBJ reporting and is currently visible on Care Compare. So this would be in addition to the total nursing hours per resident day measure that is scheduled to affect payments beginning in fiscal year 2026. So it's very easy to see here that CMS has their eyes on staffing. We already report this information and are, graded on it publicly, but now we're looking at the potential impact on providers' VBP performance as well. So we can move on to the discharge function score measure. So this is also being proposed for the SNF QRP program, as Mark mentioned. This would be another measure that's crossing over multiple programs. So this outcome measure is MDS-based. It's derived from Section GG, and it evaluates functional status by calculating the percentage of Med A residents who meet or exceed the expected discharge function score. I'm putting some virtual emphasis on the word expected, right? So the measurement or the performance period, for this measure under SNF VBP would be October 1st of 2024 through September 30th of 2025, giving us a 1-year delay in implementation of that data collection. Then we have, so the third proposed addition to the SNF VBP is the long stay hospitalization measure per 1,000 long stay resident days. So this measure is claims based, meaning it's calculated using claims data rather than MDS data. And the measurement or performance year would begin with fiscal year 2025, and the program payment year would start with fiscal year 2027. And this measure calculates unplanned discharges for those long stay patients to acute hospitals, critical access hospitals, as well as outpatient observation stays. And this is per 1,000 long stay days over a 1-year period. All right, one that I'm sure we're all pretty familiar with. So the fourth and final proposed addition to the VBP is the long stay falls with major injury measure. So this is already, as we know, publicly reported and part of the 5-star rating, but also, proposed to impact VBP as well. So this measure calculates the percentage of those long stay residents who experience one or more falls resulting in a major injury. So the important thing to note here is that RAI definition of major injury. So while an injury may, from a fall may be traumatic and it may look major and seem really bad, the only injuries that would include a patient in the numerator of this measure are listed here. So bone fractures, joint dislocations, closed head injuries with altered consciousness, and subdural hematomas. So identifying those, making sure that section J1900C is not checked unless there is, criteria to qualify it as a major injury is our big takeaway here.
And when we review MDSs for quality measures and we look at this measure, that is one of the most prominent errors we see, is classifying serious injuries as major injuries when they don't meet these one of these 4 qualifying events. So like Megan said, if something looks serious, that doesn't necessarily categorize it as a major injury. So it's a good place to go back and look and make sure your team is educated on this.
All right, so the measurement that's proposed to be replaced is that 30-day all-cause readmission measure. So we're looking at CMS to replace that 30-day all-cause readmission measure with the SNF within, these are like the longest measure names ever. Oh my gosh. SNF within stay potentially preventable readmissions. And then we've got, on the next slide, we've got a couple differences between the two. So this replacement basically switches the outcome observation window from that 30-day fixed window following acute care hospital discharge to within the stay. So the date of the SNF admission and within the stay is basically the date of SNF admission through and including the date of discharge. So we swap out that 30-day window. We're looking at SNF admission through and including date of discharge. This measure is risk adjusted and is calculated using 2 consecutive years of claims data, Medicare fee-for-service claims data. The performance or measurement period here will be fiscal year 2025 and 2026. The performance standard will be determined after that 2-year measurement period. So they're going to collect all that data. then determine, how they're going to compare. All right, so a couple of proposed policy changes to the SNF value-based purchasing program. First, we have that health equity adjustment. So this will reward facilities with greater than or equal to 20% dual eligible residents that perform well. Fiscal year 2025 will be the measurement year for that, with fiscal year 2027 being that program payment year. They're also proposing to increase the payback policy with an estimated increase from 60 to 66%. And of course, with all these new measures, they'll need to make some administrative changes. They've got to have, policies and procedures in place to accommodate all of these newly proposed quality measures, even though some of them, of course, we see in other programs. There's also a proposed data validation process to ensure, the quality of the measurement data. So MACs would be used in the proposal. MACs would be used to validate the data for claims-based measures, and then they would have an additional validation process implemented for all of the MDS-based measures.
One of the things we promised is a timeline, and unfortunately, CMS doesn't provide solid dates a lot of times, but we know every year around April, we'll get that proposed change or CMS proposed changes, which we received, along with some of the new MDS and RAI manual information. They also promised us some type of clarification in the spring, like we talked about, on their staffing mandate and their decision on that. So we're waiting for that. One of the things that CMS has done really well over the past probably 10 years or so is provided training materials, including videos that are available on YouTube for free, that really help with team training and training individuals on your staff. So you'll want to watch for that. They're great. I would insist that your staff watches those training videos, because that is the source. If you want to know how to do something, CMS is telling you what their expectations are. Then we know around the end of July, sometimes as late as beginning of August, we'll see the final rule come out, and that will solidify any of the proposed rules. Every once in a while, there's some minor changes. Very rarely there are major changes, but it has happened. But you'll want to continue watching for the final rule, to make sure that you're aware of what rules you're actually implementing. Then in August and September, of course, there's a mad dash to learn a little bit more, to implement processes, to make sure that your team is ready, make sure that you know what those changes are and what they mean to your practice in your facility. Then October 1st, we go live with that fiscal year 2024 rule and move forward. Occasionally, there are additional changes after that, but that usually is where most of the major changes end, is October 1st, as far as implementation. And after that, it really is about your practice. One of the things we want to talk about when we talk about gimme base, it's really that foundation, that support, whether it's for music or whether it's for construction. The picture on the right is actually a home that fell off the side of the mountain in Draper, Utah, several weeks ago. We've had record snow, record rain, but there wasn't adequate foundation. In fact, underneath it was basically sand, but this is $1 million and a half home that literally fell off the side of the mountain. Wasn't the right place to build. It wasn't the right foundation. And so I want you to start thinking, what type of foundation, what type of base are you providing for your teams? As a leader, a couple of things that you can do. One is have a consistent, focused, disciplined meeting with purpose. So whether it's your utilization review meeting or Medicare meeting, whatever you want to call it, your admissions meeting, your stand-up meetings, those other meetings, are they focused? Are they meaningful to your team? The other thing is to understand the changes well enough to guide your team through these. One of the worst things we can do is defer to everybody else. While we're not all clinicians, we don't all have the same degrees and expertise, you can understand these changes well enough to guide your team through them. And as a leader, that is your responsibility. You're going to work towards meaningful goals with timelines and accountability. It really is making those assignments, following up. We're putting a framework, or we're helping you to put a framework together for your teams by telling you what the items are that will most likely have changes. QAPI's been talked about for years and years and years in one form or another. But do you have a strong, focused, meaningful QAPI program? Are you picking out those 3 or 4 things that are meaningful to your residents, to your outcomes? And here's the other question. Does your team know what those items are that you're working on? More often than not, you can walk out onto a SNF floor and start talking to people about the programs that are being implemented or improved in the facility. And a lot of the people who should be helping with those implementation tasks don't know about the programs or the focus that your facility has. So good to circle around and look to make sure that your team is focused on the right things. Now, I've attended many, many, many meetings in many facilities over the years. And it's interesting when you're looking at census development and when you're looking at really developing your business and your business plan. I've sat through, I don't even know how many meetings where people were talking about their goals. What do we want to be? Well, we want to be the provider of choice. We want to be the employer of choice. And those are all valuable things. They're great goals to have. But how do those relate to what we're talking about today? Because I know you've heard this too. Your staff, your team, they want to be the provider of choice, employer of choice. You want to attract the right residents. You want to attract the right employees. Well, think about it. If you have impressive discharge function and quality measure scores, it's going to relate to being the provider of choice. You're going to prevent rehospitalization in ED visits, those unnecessary visits. You're going to be the provider of choice with your hospitals, with your referral sources. Think about vaccination percentages, whether they're flu, pneumonia, COVID, in terms of protecting your residents. And I realize, everybody has the right to determine whether they're going to have those vaccinations or not. But I want you to think in terms of protecting your resident. That's the provider of choice. Think about resident satisfaction. We now have the core Q coming on. They're going to tell us how we're doing. If your residents are pleased with your work, you're going to be the provider of choice. And then the transfer of health information. Boy, if other providers in your community are receiving information, good, meaningful information at time of discharge, and the families are receiving that information, they know what to do for the residents and the medications they're supposed to take, you're more likely to be the provider of choice because people recognize your outcomes. You want to be the employer of choice. Well, the first thing is to be fiscally stable, right? I want to make sure that we can afford to remain in our community and provide services. The SNF QRP and value-based purchase both have up to 2% penalties if you don't meet their minimum standards. So in order to be the employer of choice, you have to be fiscally sound and stable. The other thing is really to have leadership who understands the business. The business are these changes. The business are the source materials. Do you understand what the regulations say and mean? Doesn't mean that changes your licensure, but you can understand what's going on. You can understand the business. It's going to help you to decrease staff turnover because you're going to be able to allocate the time, resources, opportunities for training. Like I mentioned earlier, that's your job. That's all of our job. That is, as we work together as a team, we need to make sure we're working cohesively. And that helps us to become the employer of choice. Also setting consistent, predictable expectations for the team. And those, again, could have to do with our patient outcomes. So we're looking at that discharge measure and the quality of the care that we're providing. We're more likely to have, if we have great discharge, we have low hospitalization, we're more likely to have positive survey outcomes. We're more likely to have a selection of our admissions. And we'll really have a culture of achieving meaningful outcomes. So we're really setting ourselves up based on patient care, based on patient satisfaction, based on outcomes, based on strong leadership who understands the business and the changes, and make sure that you have the tool or the tools to accomplish those changes, that's going to set you up as the employer of choice. So got to go back and ask yourself, am I setting that strong, healthy base for my team?
All right, so let's do a little Section GG overview. So the purpose and the intent behind Section GG in general was to help CMS streamline outcomes across multiple post-acute care settings, right? They needed providers from different settings to be speaking the same language when it comes to patients' functional outcomes and goals and their abilities. So this did require a move from the rule of 3 in Section G to usual performance in Section GG. So both sections address specifically patients' functional abilities and how they are able to or are not able to care for themselves, and how much staff it requires to assist these patients. In Section GG, it does require a qualified health professional to assess the status. However, information is collected from multiple sources. So we can get that information from the patient. We can get that information from the caregivers, staff, documentation, interviews, all kinds of different places. Of course, there was and still is confusion because we're coding both Section G and GG currently. That is not how CMS intended it. I'm going to cut them a little bit of slack here. When COVID happened, we got stuck with both sections, and that wasn't really supposed to happen. So for Section GG, the information used to make the coding decision on the MDS is generally collected in a 3-day window. And those initial scores, of course, should be considered prior to benefits of intervention. A couple more items on that overview list. So Section GG will likely be used in function-related quality measures. We just don't have the details of that yet. CMS hasn't really made those decisions yet, and we don't have that QM users manual just yet. So yet to be seen. The usual performance decision in Section GG is intended to be an IDT process. So this makes collaboration and communication huge. If you have great communication with your team and you are collaborating on this coding decision, you are setting yourselves up for success in so many ways. Section GG currently drives Medicare A payment in the nursing and PT/OT components of PDPM, and as we've seen, is soon to drive SNF QRP and VBP programs. So one thing that I think we as an industry continue to struggle with a little bit is defaulting to solely using therapy documentation when coding the MDS. This coding decision cannot be one-sided. It really has to be a team effort. I feel like there are so many teams out there that really know their patients really well, but it's just not reflected in Section GG coding. We're looking at really trying to kind of pick apart the nuts and bolts of it and look at documentation and, pull this from nursing, pull this from therapy and average it. No, you guys know your patients. Come to a collaborative decision using communication and the source documentation that you have. Kind of already spoke to this, but the therapy dilemma. So, therapists are trained to facilitate residents' optimal performance, right? They set themselves up or set their patients up for success. And that really eliminates the team collaboration piece of it. It also, of course, leads to, improper goals, improper care planning and reimbursement. And it's hard to show those outcomes if you don't get a really good baseline set.
I think that's one of the most important points in this section is when we're looking at Section GG, the most common issue and mistake that we see is deferring the coding to therapy, and we're taking their performance measures. And like you said, therapists are trained to get the optimal performance. We're also seeing them for a brief window in the day, and we're seeing them when they're well rested, well fed, well medicated. We're really getting the best performance. one of the biggest issues with this is setting the proper baseline. So if we're setting an artificially high baseline, it's very difficult to show improvement. So our discharge scores, those discharge functional scores that are going to be in the QRP and value-based purchase, are going to show minimal change or have the tendency to when we set that artificially high baseline score. So that usual performance has to be just that. How do they usually do it, whether they're in or out of therapy? How do they usually perform, including when they're tired in the evenings or at night when they get up? It's all that information that happens outside of therapy. So if you're in the habit of using your therapy scores, I encourage you to rethink that process and correct it so that as you move forward, you're able to show the progress and the benefits of the care that you provided in your facility. Otherwise, you're going to show minimal benefit, and that could be problematic for you in several different ways. Okay, we're just going to review just for a few minutes some of those things we talked about. One of the most important things is understand these proposed changes and know the time frame, know the measurement years, know what you're being assessed for, what you're being judged and recorded on. Know all those things. If you know what they're judging you on and when they're judging you, you're gonna be ready for the performance year and your payment year. So know and use your source documents. Don't use rules of thumb. Don't use your resident Medicare expert who's worked there for 30 years and has known all the rules for 30 years, because rules change. You've got to keep up with the changes, make sure that you're acknowledging those changes and that you're giving your team the support that they need. Create your own plan to implement the change. Every facility is different. We know that. We all know that. There are little tiny facilities. There are extremely large, robust facilities. Not all facilities are the same. But what is the same is you should be assigning a who does what by when and have backups for assignments. You should have processes that help you to accomplish your job and not just a person who is that process. I'd go back and ask questions. I'd look to improve your current processes. I'd look at resetting and clarifying your expectations. Do people know what they're supposed to do? Super important things, especially from a leadership perspective. And I told you that we would put the references at the back. These are the sources. We put them in the front, the back. You can't miss them, cannot miss them. And just really briefly, I want to remind you, we do provide MDS oversight services, and you can see the list of things that we do there, whether it's CMI or case mix index, interim and remote MDS services. We do a lot of those things, as well as in-house therapy management, really have great review and audits, as well as branding and marketing. So whatever you need, we're here. We want to hear back from you. So we especially want your questions. Send those in to us. We're out of time today, unfortunately, but send those questions in to us. We will get them answered. We'll send that document out. And again, we're here to support you. We appreciate you attending today, and we want to hear your questions. So y'all have a great day, and I'm going to turn it back over to Amy.
Thank you, Mark and Megan, for the informative presentation. Great job. On behalf of QRM, we'd like to thank everyone for attending today's session, and we encourage you to connect with us on social media and subscribe to our blog and podcast. Megan and Mark are very active on both and providing weekly updates, so this is another great resource for you to keep an eye on. But this concludes our webinar for today. We hope you have a great day, and we'll see you next time. Bye-bye.